Hello, welcome to the webinar. Today we are going to talk about pelvic floor function and clinical considerations for strength and conditioning. My name is Monique Middlecoff, and we are going to look at pelvic floor function from the perspective of a clinical exercise physiologist and answer some questions about what do we need to know, what are the important considerations when we're talking about exercise prescription or exercise testing, and how to use the principles of anatomy and physiology and programming principles to be able to best help our patients, our clients, and our customers. Great, so why do exercise physiologists need to know about the pelvic floor? Doesn't this fall under the gynecology or urology umbrella? But I think we need to know about pelvic floor functions because it impacts the way that we move, our exercise prescriptions, our exercise testing, the implications for exercise adherence. And so it's crucial that we understand what women are going through, especially when it comes to pelvic floor dysfunction. So today we're going to talk about the introduction into the topic, talk about pelvic floor musculature, pelvic floor disorders. We're going to go through risk factors, measuring pelvic floor function, what are the tools that we use to measure it, and the implications for strength and conditioning. So let's start with what is a pelvic floor? Well, it consists of a set of muscles, ligaments, and connective tissue in the lowest part of the pelvis that provides support for the internal organs, including the bowel, the bladder, the uterus, the vagina, and the rectum. So on the left-hand side of the screen, you see the bony structure, and on the right side of the screen, you see a superior view looking down into the pelvis to be able to see the layer of the pelvic floor muscles. Well, why should we care? Why is this applicable to us? Well, this material is not often covered in traditional coursework for exercise physiologists. I didn't have any exposure in my bachelor's program, anything in my master's program, and very, very little exposure in any coursework in my PhD program. Certifying bodies, certifying organizations largely don't touch on pelvic floor function, and I think maybe that's because it's a newer field, a little bit of maybe discomfort or lack of awareness about the topic, and I think it's just an opportunity for all of us to learn and grow together. Pelvic floor disorders impact 25% of all women with moderate to severe symptoms. That's a significant group who are experiencing difficulty in their pelvic floor. This relates to balance, structural support, vaginal support, strength of the muscular contraction, and the ability to have a healthy pelvis and pelvic floor to be able to do activities we need to do and activities we want to do. Pelvic floor dysfunction is a barrier to physical activity, and we know anything that we can do to help people be active in a habitual manner throughout their life is going to lower their risk for significant other comorbidities. Exercise type, the duration, and the intensity all contribute to pelvic floor function. And we want to have our exercise prescriptions with the appropriate type, the appropriate duration, and the appropriate intensity for women who are at low risk, who are at moderate and high risk for pelvic floor dysfunction. So this just gives some context into what women experience who have pelvic floor dysfunction. So compared to healthy controls, women with pelvic floor dysfunction have a significant decrease in condition-specific quality of life. They rate their quality of life lower than those who do not have pelvic floor dysfunction. They're less likely to feel physically attractive, less likely to feel sexually attractive, less likely to feel feminine, more likely to feel self-conscious. Overall, it's a barrier to physical activity, and these women are unlikely to seek medical care, meaning their condition is going to continue without an intervention. Why should we care? Well, 11% of all females in the U.S. will have surgery for stress urinary incontinence. We abbreviate that as SUI, or pelvic organ prolapse. We abbreviate that as POP or POP. The cost. This is a big one. $11.2 billion in the community and $5.2 billion in nursing homes. That's billion with a B, not million with an M. That data was collected in 1996, so we know it has changed since then, and I'm going to estimate that it has probably gone significantly higher than in 1996. 58% of women require a second surgery for reoccurrence after their initial surgery. Well, what does that tell us? Well, it tells us that it wasn't very successful. prevention is significantly better than treatment. And once we've gone down the path of disorders and gone down the path of dysfunction, after surgery, those women will stay in the cycle of reoccurrence very frequently. It's not uncommon. And 40 to 51% of women with pelvic organ prolapse have stage 2 or greater. We'll talk about that a little bit later, of what that actually means in terms of the stage of organ prolapse. About 30% are symptomatic. Well, what does it tell us on the flip side? We can do the math, right? That means about 70% are asymptomatic. We're not able to feel or identify the symptoms associated with the condition. Let's talk about the pelvic floor musculature. Well, we have superficial layers, deep layers, skeletal muscles. That also tells us we have a portion of the tissue that's going to be under our control and a portion of the tissue that's going to be automatic or not part of our control. So we have the deep layers, and this is when we talk about the pelvic floor muscle, this is the grouping that we're typically talking about most often. That's the levator ani. These three muscles working together, the pubococcygeus, the iliococcygeus, and the puborectalis, they create that foundation, kind of the sling in the bottom portion of the pelvis that helps support the weight of all of the internal organs. So we know, just based on what we know about carrying the weight of internal organs, the heavier the weight of the organs, the more pressure pushing down on those deep layers. So let's look at what those look like in a little bit better view. So if we're looking down at the superior view, towards the front we have the frontal side and we have the coccyx shown on the back side of the sacrum. So we have the pubococcygeus. Ooh, let me get my mouse so you can see it. There we go. Okay, pubococcygeus right here. The anococcygeal ligament right down the center. There we go, the coccygeus shown on both of the back sides. Puborectalis. Good iliococcygeus here. And it forms almost a triangle here all together, combined as one. We have the levator ani group. Now they really form like a sling or the base of the pelvic floor. Let's change our viewpoint. So now if we're looking from the bottom up, we're looking at the inferior view. We have the pubic symphysis right shown in the front, and the sacrum, the coccyx shown in the back side. And it's a really nice view to be able to see the direction of the muscle fibers and how they contract. And as physiologists, we feel very comfortable with muscles, knowing concentric, eccentric, isometric types of contractions. So you can see based on origin insertion, you have a concentric contraction, an isometric contraction, or an eccentric contraction, how those muscles will change with movement. Let's talk about the pelvic vascularity. The pelvic region is extremely vascular, which is wonderful in terms of healing, tissue regeneration, and making fundamental changes based on the stimulus that we apply. The thing that's interesting is when we have any sort of vascular dysfunction, especially if we're working with patients who have vascular disease of some sort, whether it's cardiovascular disease, peripheral artery disease, we have a predisposition to have maybe impaired blood flow to the pelvic region, which could be contributing to some pelvic floor dysfunction. It's just something to keep in mind. Let's talk about pelvic floor disorders. I think this is kind of the meat of what we want to talk about. So let's talk about it in a way that can help us identify the contributing factors to know what pelvic floor disorders are and how we program around that or how we work with that patient, client, or customer. So what is a pelvic floor disorder? Well, it's a grouping of disorders affecting the anatomy and the functionality of the pelvic floor. A pelvic floor disorder occurs when women have weakened pelvic muscles or tears in the connective tissue due to excessive strain on the pelvis. So oftentimes you could have weakened muscles in the pelvic floor due to inactivity or maybe disuse, or tears in the connective tissue due to excessive strain. That could be through exercise, that could be through vaginal delivery or other means. So there's many types of pelvic floor disorders, and I'd like to start with incontinence because incontinence is the most commonly talked about, it's the most commonly heard of. There's less stigma associated with it, so it's more often in our conversations. There's been a lot of research around incontinence. So incontinence is the loss of bladder or bowel control resulting in leakage of urine or feces. You could understand why the stigma is associated with pelvic floor disorders, because sometimes it can be even awkward to talk about. But this happens in a significant group of our population to both men and women, and so it's really important to understand the implications. Prolapse, especially pelvic organ prolapse, is the descent of one or more of the pelvic organs, which is the uterus, vagina, the bladder, or the bowel, into or out of the levator hiatus. Well, we know tissue that is supposed to be inside the body does not survive well outside of the body. We need to have things in the right location, and I'll show you some visuals to be able to get a better picture of what that looks like. We also have emptying disorders falling under the umbrella of pelvic floor disorders. This could be difficulty urinating or moving the bowels. Pain. This is something that we feel more comfortable talking about often. Discomfort to the lower back, the pelvis, or bladder, and or the urethra. We feel more comfortable talking about pain, and especially when you talk about pain scales and rating pain, it's a little more comfortable to have that conversation. It's also more comfortable for patients to provide that information to their provider. Overactive bladder is also another pelvic floor disorder, and it's the frequent need to avoid bladder pressure, urgency, or urgent incontinence. That would be the feeling of gotta go, gotta go, gotta go, and not quite able to make it to the restroom in time. So let's talk about pelvic organ prolapse. The reason why I want to spend the most time in pelvic organ prolapse is because it's very limited in terms of our community as exercise physiologists, the knowledge that we have in conversations, that we share in education, and it's also the area where I have the most expertise, so I want to be able to talk about that today. There are many different types of pelvic organ prolapse, and we're also talking about skeletal muscle when we're talking about pelvic organ prolapse as a large whole. And I think it's important to know that these are things that we have control over, and we have a lot of role as our maybe exercise prescriptions evolve, as we're learning about the risk factors and the ways that we can help improve the symptoms of prolapse. Let's talk about the first type, which is uterine prolapse. So in this visual, you can see where the uterus is supposed to sit, we're supposed to live. So this is just a depiction of a healthy uterus sitting in its proper location. Also the bladder, the vagina, we have the cervix here, and our rectum. So you can see, as things have shifted, the uterus has fallen down into, and as you can see, the introitus out of that vaginal canal, which means tissue that's supposed to live inside is now living outside of the body. And this creates a significant problem that we need to address. Cystocele, also known as anterior vaginal wall prolapse, is where the front part, or the anterior side of the vagina here, has fallen down and scooched outside. Well, you can also take a peek at the bladder and see what has moved in this instance. Oftentimes when the bladder falls, using that anterior wall prolapse, it often creates a pinch in the urethra, which the symptom would be difficulty voiding or having a difficult time completely emptying the bladder. And you can see, largely due to that prolapse, it's difficult to have a normal urination. Rectocele, or posterior wall prolapse, occurs when the posterior side of the vagina is descended down into or out of the vaginal canal. So we have a bit of shifting as well with the uterus in this case, because we have a significant prolapse that has occurred. Enterocele, or vaginal vault prolapse. What is missing from this picture? Can you take a second to look for it? That's right, this lady does not have a uterus. She's already had a hysterectomy. And in that case, the uterus was filling space, and it's no longer filling space. And in this instance, it's common that we would have the internal organs pushing extra pressure down, creating an entire vaginal vault prolapse, scooching down into and out of the vagina. It almost folds on the outside. You can see this whole outside. It's just in the wrong location. I didn't give you a heads up or a forewarning, but symptoms of organ prolapse, you can see the symptom from the outside just by looking at this picture of a stage 3. So we have mechanical symptoms that you could feel pelvic heaviness or vaginal bulging. Clearly in this instance, vaginal bulging would be appropriate. Bladder symptoms such as stress and urgent incontinence. Stress incontinence would be something like jumping, laughing, sneezing, coughing, and having an associated urine leakage. Where urgent incontinence would be that gotta go feeling. Also, straining to void would be very common when we had maybe a pinching or a tightening of the urethra. Bowel symptoms such as straining to void And I didn't write it out completely, but the acronym here, IAP, stands for Increased Intra-Abdominal Pressure, meaning really having to push and strain to void the bowels. Sexual symptoms such as pain and discomfort are common. So what are the implications? Well, here we're showing different stages, but we have 40 to 51% of women with pelvic organ prolapse have stage 2 or greater. And I've already mentioned that about 70% of those women are asymptomatic, meaning they're not identifying or feeling the symptoms associated with the condition. The ones who are have significant self-efficacy decreases, so they're not as confident, not as sure, not able to see themselves as able to do the activities that they would like to do. It's a barrier to physical activity, and anytime we can remove a barrier, whether it's something small or something large, we give women the opportunity to be able to meet the physical activity guidelines in a way that's really possible. Less than 15% of women in 2008 met the CDC guidelines. That is too low. It's absolutely too low. We need to raise that number, especially when we're talking about the 150 minutes of cardiovascular exercise, 2 days a week or more of strength training for all major muscle groups. That is a doable recommendation. We need to help remove any barrier that keeps women from pursuing exercise or being adherent to their exercise prescription. 60% of U.S. adults are overweight or obese. That includes men and women. And while we're talking about pelvic organ prolapse, that largely relates to women, and that we know that men experience pelvic floor dysfunction as well, and it really does impede balance, especially because of the coccyx and the way that we have sacroiliac joints. It plays a huge role in our posture, stability, support, and the way that we ambulate. So it's important that we're addressing pelvic floor muscles. For those who are in kind of the cascade of inactivity, when we have a barrier of physical activity that kind of is difficult to overcome, we have this cascade of chronic disease where we have physical inactivity and perhaps maybe poor eating habits associated that leads to osteoporosis, atherosclerosis, diabetes, can lead to arthritis and depression. And anywhere we can stop the cycle, that we can really make a difference in our patients' lives. Let's talk about risk factors. Who is at risk for pelvic floor dysfunction? Well, is it just elderly women who are extremely frail? No, it's not. Absolutely not. We do know that we have a limited understanding of the pathogenesis of pelvic organ prolapse. We don't have a perfect maybe guide that we could walk through to identify every single contributing factor. But we do know there are some really large contributing factors that we can identify that we do know of, and it's important to talk about them and use them as a risk stratification for our patients. Let's first talk about vaginal delivery. Vaginal delivery, and especially the number of parity or parous women is typically how we would refer to it, the more vaginal deliveries a woman has, the more likely that she is going to develop pelvic organ prolapse. This is not true with cesarean sections or cesarean delivery, so we know that vaginal delivery is one of the initiating factors for the cascade of pelvic organ prolapse, largely due to lacerations, especially in the levator ani. Just kind of briefly showed the anatomical view of how it sort of serves as a triangle or a sling in the pelvic, the base of that pelvis. And if that is crushed or elongated while a vaginal delivery is occurring, often we get levator ani tearing at the same time, and it can result in the development of pelvic organ prolapse. At that point in time, it's not reasonable in many cases to perform an MRI or to have any additional test performed to identify if a levator ani tear has been or has occurred, during that vaginal delivery. One of the second risk factors is a pelvic surgery or a hysterectomy, especially when you saw the vaginal vault prolapse. As the tissue tends to shift downward, it puts more pressure on the pelvic floor muscles themselves. Connective tissue disorders and joint hypermobility. Now, this isn't one that would occur very frequently, but it's a high risk factor. For those who have connective tissue disorders, pelvic organ prolapse is extremely common in that population. The fourth risk factor, obesity, especially for those who have a BMI over 30 or over 29.9. we know that that cutoff point of 30 is associated with higher rates of pelvic organ prolapse. Now we have this physical activity risk factor that has multiple pieces, and I'd like to talk about them just a little bit. We know that the American Urogynecologic Society has recommended to avoid heavy lifting for those who are at risk. And heavy lifting is described very interestingly as 10 pounds. 10 pounds or more is considered heavy lifting. And that recommendation has been a part of the OGS for since 2014. So it's been there for a while, and it is really unique when we talk about the role of physical activity, because what one person might consider heavy lifting versus another is up to a bit of interpretation. Age. Age is a risk factor for pelvic organ prolapse, largely due to muscular changes, maybe due to sarcopenia or inactivity. And as you get older, we see the rates of pelvic organ prolapse also raising in that instance. Smoking is another risk factor. We see a compromised vascular system, and especially for those of us who are working in a cardiopulmonary rehabilitation clinic, or those who are working with maybe cancer survivors or patients who are going through treatment, we know that smoking cessation is a big promoted activity. And if we can really help decrease the rates of smoking, we can significantly impact the vascular system and maintain the pelvic vascularity and to keep those tissues functioning properly. Just a note, this isn't a risk factor specifically, but medications can significantly exacerbate symptoms. So when we're talking about maybe antidepressives, we're talking about Lasix, we're talking about maybe an alpha blocker, this is a medication group that really can exacerbate the symptoms, even just with Lasix or a diuretic, as we have an increased urine output. Issues like urination or urine leakage are just more common because we have more urine available. So let's talk about physical activity and pelvic floor disorders for a moment. We know that women after Title IX have been significantly, let's say that a different way, women have been participating in physical activity in higher rates, in higher intensities, doing things like CrossFit, Olympic lifting, military-style boot camps, often using improper lifting technique, not always, but often using improper lifting technique and then performing too much too soon. And I think it's just worth noting that we want to make sure that our bodies are able to perform the exercises safely, whatever that exercise prescription is, throughout the continuum, whether we're talking about youth sport participation, through collegiate athletics, through Olympic participation, to our recreational athlete, to those who are maybe experiencing physical activity and exercise for the very first time at older ages. Wherever our patients, customers, or clients are in that continuum, we need to be able to meet them where they are to help them identify their risk factors. And with this, improper lifting technique could be at the Olympic level, or it could be all the way down at the very beginner level. So we need to help identify some of those factors. High intra-abdominal pressure and high ground reaction force, whether that is an acute stimulus or whether that's a chronic stimulus, contribute to pelvic floor dysfunction. And I think it's really helpful to understand whether we have maybe symptoms that are acute, which would be something like urine leakage due to stress urinary incontinence, or a chronic condition, something like pelvic organ prolapse, that does not resolve once physical activity is complete. Let's talk about pelvic floor function and strenuous physical activity. So we know with those who've had significant strain on the pelvic floor, especially when we're talking about those who are at an elite level, we see a thickening of the levator ani diameter, meaning that muscle, that sling muscle as a whole, when we're talking about pubococcygeus, iliococcygeus, puborectalis, that muscle really gets thick on those who have constant strain on the pelvic floor. And when we look at paratrooper recruits who are compared to Army recruits who did not do paratrooper training, the paratroopers who experienced landing and forceful repetitive landing experienced decreased vaginal support. So their maximal vaginal descent score increased, which indicates decreased support over time. And strenuous physical activity in the teenage years raised the odds of incurring pelvic organ prolapse later in life. We didn't see that same increase of odds ratio with lifetime physical activity, which just tells us that we need to be mindful when we program for strenuous physical activity in the teen years that we could be potentially creating harm later. So if we have someone who maybe does not have the strength and support in their pelvic floor doing exercises that have high ground reaction force, high intra-abdominal pressure, we could be setting them up for injury later. So it's just something we need to think about. Vigorous physical activity. High intensity exercise that is beneficial for the cardiovascular system may be contraindicated for at-risk women. This study looked at 144 female athletes, so this is looking at an athletic population already, and they're young women, about 19.9 years, so we have a mean age of around 20. When we look at participation in gymnastics, basketball, tennis, field hockey, track, swimming, and golf, look at the percentage of women who experienced symptoms of stress urinary incontinence. We can see gymnastics has a high intra-abdominal pressure, high ground reaction force, high impact. 67% of the women in this study who were gymnasts experienced stress urinary incontinence. Now, let's look down at golf. Golf has a very low impact, low ground reaction force. With any swing, as we're taking a swing, golf had 0% of the participants experience symptoms of stress urinary incontinence. That's just, again, it's something we need to consider. Urinary incontinence and elite nulliparous athletes. Nulliparous, just in case that's a new word to you, that just means no parity, no children, no vaginal delivery. This is just showing a different way to look at the same data. So we see black indicating frequently, this gray color indicating sometimes, rarely, and just once. So we can see for gymnastics, a significant portion of that 67% experience frequent stress urinary incontinence. They're leaking urine on sport participation very frequently. And we can see all the way down to the sports of tennis, basketball, field hockey, track, volleyball, swimming, and softball. Those rates significantly decline. Great. Let's discuss some fatigue-related pelvic floor changes. Nulliparous, again meaning no parity. Females leaking during physical activity. When we look at this group, we had a low sample size, 12 participants. Their age was about 24 years. No major risk factors for pelvic floor disorders except for the symptom of mild symptoms of SUI, stress urinary incontinence. Their conclusion was the mean maximal voluntary contraction pressure decreased by 20%. So the voluntary contraction pressure, squeezing as hard as possible, decreased by 20% after physical activity, meaning their pelvic floor muscle strength decreased when they had finished their activity bout. So strenuous exercise results in lower maximal voluntary vaginal contraction pressure, which just indicates pelvic floor muscle fatigue. Now, is that an acute change? Is that something that just changes for a few minutes, a few hours, a few days? Now that we don't know for sure. Let's look at a study we did just recently. We found decreased vaginal support for both strenuous and non-strenuous exercisers post-exercise. So if we looked at a group of women who routinely and habitually performed strenuous activity versus a group of women who performed non-strenuous activity habitually, and we looked at their scores before and after exercise and then compared them to each other, we found that vaginal support decreased for both groups. That indicates that the tissues, either due to temperature or fatigue, experienced some additional laxity. And the vaginal resting pressure decreased additionally for strenuous exercisers. It's indicated right here. And no change was found in pelvic floor muscle strength in this specific group pre to post exercise. So while there was additional laxity indicating lack of support in the pelvic floor, we don't know if this change lasted for just a brief moment or if this was sustained over time, leading to a propensity to experience pelvic floor disorders later in life. Can we predict pelvic floor strength with appendicular strength? Meaning, could we predict if we have a stronger pelvic floor, if we have stronger arms or stronger legs? Well, we found the answer is a resounding no. And this is a very unique measure. So pelvic floor muscle strength, we don't experience a concurrent increase in our pelvic floor muscle strength as we're performing lifts maybe in our upper or lower body. Now the question, do women with higher appendicular strength, arm or leg strength, have higher pelvic floor muscle strength? I thought yes, absolutely yes. If you're stronger and you're constantly putting yourself through a higher exercise stimulus, whether it's maybe something that's very pre-planned and structured in a training program, or something that's recreational, if you're doing higher work in your muscular system, that you'd experience a higher strength in your pelvic floor as well. Well, we found that is not the case, not at all, not even closely correlated. So that tells us it's a unique measure, and we know due to muscle specificity that it's important that we purposefully target the group of muscles that we wish to strengthen or change. And if we're not purposely strengthening or changing our pelvic floor muscles, they don't magically increase in strength and endurance. Okay, let's talk about pelvic floor function. So there's multiple ways we can measure the pelvic floor. Now, I don't know about you, but I don't know any woman on earth who would be excited about seeing that wheeled into a room. So now let's talk about the ways that we can measure the pelvic floor. So we can measure through palpation. That would just be through tactile touch. The Brink's test is a very common test. It's a subjective score to measure pelvic floor strength. Oxford grading system is very similar. And then we have a POP-Q, which is a pelvic organ prolapse quantification test that uses a measurement tool along with palpation. Contraction pressure, we could look at a pressure transducer. So something like a myomometer or a dynamometer, this would be an example of a periodometer here. This is a very common biofeedback tool, and more physical therapists are starting to use these tools in their practice. This is an example of a dynamometer. The University of Michigan has patented this vaginal dynamometer. And I think while the actual practical applications are huge, we still have a ways to go in terms of making this very easy to use for clinicians. We could talk about the magnitude of contraction using something like an EMG, and we can use imaging tools like an MRI or an ultrasound. Now, one thing to note is, especially when we're looking at something like vaginal delivery, using an MRI and an ultrasound might be the only tools that we could easily see some sort of tearing in the levator ani. Our other systems might not be able to pick up that type of change in the pelvic floor. What are some treatment options? Well, I don't know about you, but I had never seen a pessary before. I had never even heard of that word. But this might be something that's review to you, or something that is brand new. It was brand new to me about 5 years ago. So we have a lot of treatment that are available for patients, and we can do significant things with medication, and especially when we look at timing considerations. For example, taking a LASIK in the nighttime versus taking a LASIK in the morning, depending on when you want to be active and how many times you would need to use the restroom during that time period. We could limit frequent urination or any sort of incontinence just based on the timing of the medication. That can help significantly. Now, a pessary, this is just showing a very common pessary that's helping to hold the uterus in place. So it's just placed vaginally. There's many types, and these pessaries can help maintain the pelvic floor function. This is just a more common, let me change that. It's actually not more common. It's just a newer option available to women, and it's being heavily marketed to women who are performing high-intensity exercise. Okay, what about exercise as a treatment option? So I'm sure we've all heard of pelvic floor exercises, especially when we're talking about a Kegel exercise. That's something that's very common. But should we be prescribing Kegel exercises? Is that something that we want to prescribe as exercise physiologists? Let's talk about that in just a bit. Moderate exercise versus vigorous physical activity. Well, for those who already have pelvic floor dysfunctions, vigorous physical activity might actually make their symptoms worse. So we need to find a way to safely strengthen the muscles, strengthen the bones, and safely work our cardiovascular system without causing additional symptoms or additional problems. Physical therapy is a great treatment option with or without biofeedback. I had showed a picture earlier just of the aperiodometer, and that's a great tool to provide biofeedback, to have some more objective measures or objective pressure sensor units to be able to identify strength of contraction, and also making sure that we have the right type of contraction, because contracting the abdominal muscles are not going to strengthen the pelvic floor. Surgical intervention, obviously, through a urologist or a urogynecologist is a fantastic option for those who need it. Okay, let's talk about pelvic floor muscle exercises. We know that they are highly beneficial for the prevention and treatment of stress urinary incontinence. Significantly, extremely good results showing lower rates of symptoms and lower rates of return, especially postpartum. Absolutely encourage pelvic floor muscle exercises. And I think one of the big take-home messages is that we can't have a false sense of security, especially if we're prescribing exercise to those who are in a higher fitness category, that we have a false sense of security that because they are stronger appendicularly, that they're going to experience a concurrent strength increase in their pelvic floor muscles as well. That's not the case. We have to specifically target the muscles in order to find a strength benefit, strength and support benefit. Now, pelvic floor muscle exercises, it's inconclusive when we look at the results for pelvic organ prolapse. Does it help specifically? Potentially. And some of the results are looking at absolutely yes, or we haven't seen any improvement. And so I think one of the biggest take-home messages is that it cannot harm or cannot hurt by strengthening that muscle group. If anything, we might delay some surgical interventions, and at that point in time, pelvic floor muscle exercises would still be appropriate, but might not be the only treatment option that we look at. Let's talk about implications for strength and conditioning. Okay, let's talk about some questions right off the bat. Should clinical exercise physiologists diagnose pelvic floor dysfunction? We know this one right off the bat, right? It's not appropriate. Diagnosing is not where we should practice. We can certainly use tools to help identify women who are dealing with some pelvic floor dysfunction, get additional treatment, maybe send a referral, but it's not appropriate to diagnose pelvic floor disorders. Should clinical exercise physiologists recommend that women avoid high-intensity exercise? Improper conclusion. That's not the best interpretation of the data, especially for those who are at low risk and those who are concurrently performing pelvic floor exercises. We can safely perform high-intensity exercise. The concern comes in when we are having high-intensity exercise with high ground reaction force, high intra-abdominal pressure for those who are at risk or already experiencing pelvic floor dysfunction. That would be a mismatch. Should clinical exercise physiologists modify exercise for those with risk factors or symptoms of pelvic floor dysfunction? You got it. Of course. Absolutely yes. We need to take some extra considerations and know that we need to be encouraging pelvic floor exercise and consider referring to a women's health specialist. So what is our role? What should we do? Okay, first thing, we want to ask the potentially uncomfortable pre-exercise questions. We want to be aware of the symptoms and the concerns. If this is a barrier, let's talk about it openly and comfortably where patients feel like their needs are being met. Let's make adjustments when necessary. If that means for someone who's experiencing incontinence that we purposely build in extra bathroom breaks so that leaking urine is not a part or as big of a concern, absolutely. Let's limit high intra-abdominal pressure exercises. So if we're doing something like a clean and jerk or a snatch, we want to be very, very aware of those women who are at risk. Do not assume that women who are very fit and active have higher pelvic floor strength. This is an easy one to miss because we make that association so quickly. Women need pelvic floor muscle strength training in addition to total body muscle training all the time, especially for those who are experiencing some sort of vascular disease. Okay, so I mentioned, let's ask the tough questions. What are the questions that we should be asking? Ask the question, do you leak urine with physical activity, coughing, or sneezing? What's that question leaning towards? Stress urinary incontinence, you bet. Okay, next question, when did your urinary incontinence symptoms begin? Have you had urinary incontinence symptoms before? Has the frequency of your symptoms changed with your medication? That can indicate maybe something as simple as a medication change or a timing change can really help alleviate some of the symptoms. Do you have pelvic pain, heaviness, or bulging? That's getting at pelvic organ prolapse, although we know about 70% are asymptomatic. So we have to interpret that question with a grain of salt. Do you regularly perform pelvic floor exercise? If the answer is no, that's a perfect time to use our activity coaching to help encourage women to routinely and regularly perform pelvic floor exercise. Okay, here's a checklist. It's just a quick checklist that I just typed up so that we have something to go off of to say, ooh, okay, do we have a female over age 50? Yes, no, or unsure. Well, we know the unsure column doesn't apply in that case because if we have a patient in front of us, we can get that information. Has she experienced a vaginal delivery? Does she have the risk factor of a BMI over 30? Does she leak urine with physical activity, coughing, or sneezing? What about vaginal heaviness or bulging sensation? This gets back to the questions we're asking. Is she currently taking Lasix, an alpha blocker, or an antidepressive? Does she regularly perform pelvic floor exercise? Does she have a desire to participate in higher intensity exercise? If so, that means we have a consideration for strength and conditioning. Right? Is she a current or previous smoker? These are important things that we need to know as it relates to the pelvic floor. Okay, so let's think about our considerations, right? Our population, we know that 25% of all women have pelvic floor dysfunctions impacting posture, balance, strength, and pelvic support. We can't escape this number, so we need to know who we're working with. We should screen populations for risk factors, especially if you're working with a high percentage of women in your practice or in your business. It's important that we're screening the population. Be aware of the mode of exercise. If we're doing plyometric, jumping, bouncing type of activity, for those who are at risk, we're probably going to exacerbate their symptoms and potentially make matters worse. So, right, first, do no harm. Let's make sure our mode of exercise is appropriate. Identify sources of increased intra-abdominal pressure. So teaching a Valsalva maneuver, which is going to help with spine stiffness. If we are limiting Valsalva maneuver, we're going to lower intra-abdominal pressure and core support during lifting. So the core is not going to be as supported as we're performing those lifting activities because we're going to be continuously breathing through the exercise, which is going to lower the intra-abdominal pressure. So we need to think about that in terms of loads, especially when we're lifting overhead without pelvic support. This is a big one, and this is the new one. Avoid unsupported pelvic floor muscles with high intra-abdominal pressure or appendicular contraction. Ooh, what does that mean? Okay, so if you were to think about something like doing a dip where we have our appendicular contraction, so we have the upper body contracting significantly, a significant amount of pressure in the intra-abdominal pressure cavity, and no pelvic floor muscle support, right? The feet are off the ground in that instance, and so it's very harmful for those who are already experiencing pelvic floor dysfunction. What are some resources for patients? This might be a resource for you too. If you haven't ever gone to these websites, I really encourage you to go. So the AUGS is the American Urogynecological Society, and they are absolutely fantastic. They're female pelvic medicine and reconstructive surgeons. Ooh, that's a tongue twister. And they have developed a significant amount of information for patients and providers. So if you haven't gone there already, I really encourage you to go there for more information. And Voices for Pelvic Floor Disorders.org, or PFD, is a wonderful resource for your patients to be able to get handouts, PDF documents to describe conditions. It's written in the voice of the patient rather than the voice of the provider, so it can feel very comfortable speaking the language of pelvic floor dysfunctions as the way it would be communicated in a conversation. So let's finish today with just a few things, the do's and don'ts. These are provided right off this website down here, this Voices for Pelvic Floor Dysfunction. So what should our patients do? Well, we should encourage them to maintain a normal body weight, right? Overweight and obesity are a risk factor for pelvic floor disorders. So exercise your body and your pelvic muscles, right? They go hand in hand. So we should encourage 150 minutes of cardiovascular exercise each week, 2 or more days each week of strength training and pelvic floor muscle exercises throughout each day, right? Choose high fiber and drink plenty of fluids. We want to make sure that we have regular bowel function. So if we're frequently constipated, we have straining with defecation, which can be problematic. Get your health checked regularly. Chronic cough increases abdominal and pelvic pressure. Get it treated. Also, I'm going to add on here, do address low back pain, because low back pain, chronic low back pain, can lead to pelvic floor dysfunction. So really pay attention to those who are experiencing chronic low back pain. Don't smoke, we know that. Don't perform repetitive strenuous activities. Ooh, see, as exercise physiologists, we see this one and it's a little concerning because strong muscles are important for general health. That's the recommendation. Extreme repetitive activities put a stress on the pelvic area. So we know for those who are experiencing symptoms or who are at high risk, we need to really watch this one. Use your low back or abdomen for heavy lifting. Learn how to safely lift with your legs. I'm sorry, I didn't clarify that one. Don't use your lower back or abdomen for heavy lifting, right? Because that's going to increase intra-abdominal pressure, putting additional strain on the pelvic floor. We don't want to strain during bowel movements. Chronic straining and constipation increases your chance of developing prolapse. So those are just some things we want to communicate with our patients as often as possible. Pelvic floor disorders impact 25% of all women with moderate to severe symptoms. Whoa, that's a big number. We really need to watch our population, know who we're dealing with, know how we can help. Exercise testing and prescription should include safety considerations for pelvic floor precautions. In cardiopulmonary rehabilitation, we often talk about sternal precautions after a sternotomy, but we don't often talk about pelvic floor precautions, and I just encourage you maybe to think about that in a different way today. So implications, we know that pelvic floor disorders are a barrier to physical activity. Let's remove the barriers that we can remove. Decrease self-efficacy. Let's give women confidence to know that they can have these conversations with their providers, to know that there's treatment available, and to know that they don't need to stop exercising, but maybe modify the exercise they do. Especially because of the disease cascade, anytime that we can put a wrench in that disease cascade to help stop the process, improve our health, we're going to make a big difference in the lives of our patients, our customers, and our clients, and in ourselves as well. So let's really do our very best to use an additional consideration when we're talking about programming exercise. Thank you. We are all finished. If you have questions for me, please contact me at any time. My name again is Monique Middlecoff. You can contact me at moniquemiddlecoff@gmail.com. Let me spell it just because that is a long name. It's MoniqueMiddlecoff@gmail.com. Thank you so much. If you have any questions, I'm happy to help answer those questions. Have a wonderful day.